death by treatment, by offering radical surgery, will be much higher than the cancer itself. These are the studies. Definitely, these are not like level 1 or level 2 evidence. At the best, they present us level 3 evidence. But I will only talk about the positive aspect, which is the cancer-specific survival in such patients, which can range from 70 to 95% if they are managed even with the kidney sparing surgery. Again, this is from the percutaneous management, where we can see that the cancer specific survival can range up to 90%. So to my friends from the radical group, I know that the endoscopic management is quite challenging. We have limitations associated with the narrow ureter, with the invasiveness of the treatment. And the surveillance after kidney sparing is again not very well defined. It is again very challenging, cumbersome, and we need to have a lot of dedication. But I know that you are in majority today as far as the level of evidence is concerned, as well as the, but however, we can definitely give you a challenge in future if we stay united. Thank you.
Okay, thank you, Neeraj. So may I now request Dr. Nayak to please come for the rebuttal.
Thank you, Narjun and Professor Anishar, for the invitation. So my role is to defend Dr. Himanshu against renal preservation in upper tract TCC. I have no disclosure. So since we are having a debate means there is a controversy, but to me actually there is not much controversy in the management of upper tract urothelial cancer. So, but if you look at the literature, you can find data both in favor and against the topic that has been given. So you can find the data that suits you, you can present in front of the audience to defend your data. But the main question is whether feasibility should be the main deciding factor main guiding factor to decide the treatment option. The answer for that is an emphatic no. The answer for cancer surgery is the oncological outcomes, and since it is related to the kidney, the CKD outcomes and the complications, these are the factors that should be taken into account while deciding the treatment option. Both Dr. Uday and Dr. Neeraj, both of them actually highlighted the development of CKD in their slides. So I will just talk into the CKD, whether the patients do develop CKD after radical surgery. So Dr. Himanshu has already highlighted most of the important issues regarding the recurrence and the complications. I will just briefly go through 2-3 literature. This is a comparison of oncological outcomes after segmental ureterectomy or radical nephroureterectomy in upper tract cancer from a large multicentric French study. So what they say, what do we know about the topic before this particular study, and what this study added to the literature? Before this particular study, the convention is, since the upper tract urothelial cancer is very aggressive, radical nephroureterectomy with bladder cuff remains the gold standard treatment. However, conservative strategies like segmental ureterectomy and endourological treatment have been developed in patients with imperative indication. You should remind the word patients with imperative indications. There are people, those who are also advocating these conservative treatment options in elective cases. So they found out in their series of approximately 500 patients, 52 patients who underwent segmental ureterectomy and 416 patients underwent radical nephroureterectomy. They find there was no statistical difference in oncological outcome. But this was a very heterogeneous comparison. So, but they did also, to be fair to the authors, they also tried to do a subgroup analysis. In the subgroup analysis also, they did not find any difference in the oncological outcomes. But if you look at the subgroup, that subgroup included patients with tumor size less than 2 centimeter and low stage. So in this select group of patients, those who are having low stage and low volume disease, if you give them conservative management, they will have an equivalent oncological outcome. So their conclusion was short-term oncological outcomes after conservative treatment is equivalent to radical nephrectomy in select group of patients. In every other case, radical nephrectomy remains the gold standard. This is, I think, Dr. Himanshu has already highlighted this. I don't want to go into the details. This is an review by the European non-muscle invasive bladder cancer panel. They have also come to the conclusion kidney sparing surgery is only for the patients with very selective patients like low grade and low stage disease. So as per the oncological outcomes are concerned, there is not much debate on this. This slide has already been highlighted by both the groups, both the teams. The guideline recommends to offer conservative surgery. All the parameters of the low risk has to be fulfilled. But if any one of the parameters from the high risk category is present, that patient should undergo radical surgery rather than a conservative approach. So this guideline is already recommended to give conservative treatment. The patient should have a low risk tumor and radical surgery for high risk tumors. So the point against preservation, it's difficult to actually accurately grade and stage the disease for the upper tract TCC, and the biology of the upper tract TCC is completely different from that of the bladder cancer, and there is no effective local or topical agent. At least there is not enough data to show the topical agents. Unlike in bladder cancer, there is no effective local and topical agents for adjuvant therapy. It requires expertise and technical challenging to resect the upper tract tumors endoscopically and also need costly instruments. And frequent endoscopic follow-up during follow-up after the surgery leads to morbidity, ureteric stricture, and also adds to the cost. So the main important factor that Dr. Uday actually highlighted regarding the development of the CKD, this is an important article from New England Journal of Medicine, the long-term consequences of kidney donation. This particular paper actually highlighted the overall incidence of overall evidence suggests that the living kidney donors, the survival and the risk of ESRD is similar to that of the general population. One can argue the patients, those who give kidney donors, they are highly selected group of patients who are otherwise healthy, but the evidence still says the patients, those who donate, they do not develop ESRD or they have significant complications in comparison to the general population. Again, this is another important article on survival and functional stability in chronic kidney disease after the surgical removal of the nephrons. Here, over a decade, there were 4,300 patients, those who are treated for the kidney cancers. During their follow-up, these patients were divided into three groups, three different cohorts. One cohort, there was no preoperative CKD, and after nephrectomy, they developed CKD. So that was, they had also no CKD. So that was one group, no CKD before surgery and no CKD after surgery. The second group, they had no CKD before surgery, but they became CKD after nephrectomy. That is surgical CKD. The third group was, to begin with, they had CKD and also continued to have CKD after nephrectomy. That is medical and surgical CKD. So when they followed these patients on the long run, they found the patients, those who develop surgical CKD, the kidney function stability and non-renal cancer mortality is similar to that of patients, those who have no CKD. So the conclusion is, they come to the conclusion, surgical CKD is associated with more stable renal function and better overall survival than medical CKD. So this is again another review of, is all chronic kidney disease created is equal? If you look at this Kaplan-Meier curve, the upper two graphs shows patients, the blue curve shows no CKD, the green shows surgical CKD, and the yellow, red curve shows medical CKD. The overall survival of patients, those who have no CKD and surgical CKD is almost similar. So finally, these are two review articles that have already been published on this particular topic, nephron sparing approach in upper tract urothelial cancer, current and future strategies. The conclusion from this trial, the segmental ureterectomy and endoscopic treatment to preserve renal function have shown adequate oncological results in select group of patients with low volume and low grade disease. Currently, the efficacy of the intraluminal therapy is questionable. Similar, this is recently published in 2021 by Dr. Chandru Sundaram. Similar conclusion, the nephron sparing approach should be strongly considered for those with low volume and low grade disease for oncological control, and the added utility of intraluminal therapy is still in question because of the mixed results. So the take home, as per oncological efficacy, it favors radical surgery than renal preservation. For CKD, it's a no practical benefit of renal preservation over a long run because surgical CKD is as good as no CKD. The cost and complications of frequent follow-up with endoscopy of the patients, and there is no strong evidence in favor of the topical agents. So surgical oncological control remains the number one priority. No curative systemic therapy to salvage unresectable local recurrences. Recurrent disease is potentially lethal. So it's you to decide when you want to, whether you want to jump from a 30 feet height to a concrete and die, or you want to jump from 10 feet height on a sand, go home just injured. One can do the surgery, doesn't necessarily mean one should always do it. It's better to be safe than sorry. Thank you.
Thank you, Dr. Nayak. So I think, as in all these malignancies, we have to look at the patient factor, the tumor factor, and the kind of treatment which has been offered. So all four of them have very nicely reviewed the subject. So I think we need maybe expert comments from maybe Dr. Gupta, please, if to basically summarize.
No, I think so. All the four speakers have very clearly mentioned low-grade tumor, and where you want to have a single kidney or it is obligatory to preserve the renal function, you should go for conservative. Otherwise, a radical nephrectomy with cuff resection in Indian scenario, I think is still the standard of care. Only thing is you have not added the age of the patient and patient selection choice also, you know.
Yes.
I have some patients came to me about 85-year-old, and the children said, no, sir, we don't want surgery endoscopically. So I did the fulguration of the tumor endoscopically with laser, kept him on follow-up. He came back after 2-3 times. After that, I don't know what happened. So what I'm trying to say, yes, conservative treatment is advisable wherever it is indicated.
Any other comments from audience? Dr. Seth may like to add something.
I just wanted to share a very recent experience. There's a patient who has bilateral upper tract TCC and reasonably extensive, which cannot be tackled endoscopically. So there is no option for him. So I told him that, sorry, we don't have any option. And he is reasonably fine over the last 1.5 years. His disease has progressed, but he continues to have a good renal function. He continues to have a good quality of life. He is doing everything that is possible. Only imaging wise it is kind of increasing. That is it. So what I'm saying is that biology obviously is most important, and there can be some conservative management also for a low grade upper tract TCC, especially in an elderly. The issue that was brought out by Dr. Gupta, I'm just kind of extending what he has said.
So if it is a high grade distal ureteric tumor, what would be your take? High grade somewhere in the distal ureter? No lymph nodes and all.
High grade, yes, we have to take care of it. And if the patient is elderly and if the patient has other comorbidities, then segmental resection is acceptable, is definitely something which we will go ahead. But at the same time, if nephrectomy cover bladder excision is possible, then definitely that is to be preferred. Only if the patient cannot withstand radical nephrectomy cover bladder. In a high grade disease is aggressive disease, and even lymph node dissection is also recommended, not just nephrectomy cover bladder excision. So high grade disease, lower ureter, not only nephrectomy cover bladder excision, but even lymph node dissection should also be carried out.
Yes. Yeah, please.
There was one patient of mine who was a T1 high-grade non-muscle invasive bladder cancer patient who was on intravesical BCG therapy. Because he was, from that point of view, he is fine without any recurrence and everything. So on follow-up, he developed left-side hydroelectronephrosis. So when we evaluated that, there was a lower ureteric stricture which he had, and that was on CT scan. It was looking to be like full thickness involvement of the entire ureter. Initially, we thought that it could be like some because of the therapy itself, maybe he might have developed some inflammatory stricture. But we did a ureteroscopy and did a biopsy, which turned out to be suggestive of high-grade urothelial malignancy. And the patient was very young. Of course, he was like 52-year-old with a good functioning kidney because it was detected very early. We initially advised him for this nephrourectomy considering the full thickness involvement like T2 disease on imaging wise. But he was adamant that kindly consider any conservative procedure for that. So in that case, we selectively did distal uretrectomy with bladder cuff excision, and even we did the lymph node dissection on the same side, left side. The nodes were negative, and the biopsy came out to be T2 only, with the reimplantation and everything. And but surprisingly, the report mentioned that the margin was very close on the left side, at the level of the bladder cuff. So we have given adjuvant, considering they discussed the case with the radiotherapy colleagues, and he was given adjuvant chemo RT as well. And he is now 2.5 years down follow. The recent CT scan and CT urography was showing no upper tract recurrence or anything, and otherwise he is fine. I mean, this is one case which we had the experience.
Okay, thank you, sir. I think in interest of time, the message is very clear, and thank you everyone, all the speakers and audience. Thank you very much.
Thank you, Anish sir. I'm very sorry I asked you to session because we are running late and we have a lot of sessions pending, and I think hope to finish it on time. Now we come to the almost the last part of our scientific program. And now, may I request Dr. Ashwin Philip, Dr. Amit Dhiman, Dr. Pamela, Dr. Yogesh, Dr. Tejpal, and Dr. Nitin to come on the dais for the next session. There are 3 talks in this session, but Dr. Anil Mandani, because of some technical reasons, have not come. So we have only 2 talks left. We'll request you to please carry on. I will request Dr. Yogesh has to leave also early. So if we can have Dr. Yogesh talk first. Dr. D.S. Sandhu sir, please join us.
For the last session, the first speaker, Dr. Yogesh Cyril, he'll be speaking on overview of Wilms tumor and current treatment.
Well, I'm a pediatric surgeon, but I'm not a guest artist because I am still an associate life member of USI in spite of many requests. Abnis was here. Since 1997, I've been a life member of USI. Thank you very much, Dr. Singh and my other friend, Dr. Singh, who's left just now. The other Singh has been my classmate about 30, 40 years back. So this Wilms tumor book was published in October of last year. Springer has already earned 2.5 crores on it, gave me only 1 lakh. But I think if I'm invited again to talk about it sometime, I'll distribute some free books on it. So let me start with the timeline. It's very, very important to know that there are 2 cooperative groups across the Atlantic which have been started working since 1970 or so. 1969 was the NWTS and 1971 was the SAOP, and they've been working on it. And then they later realized that, the chemotherapy that they were giving also giving side effects. Then they realized that the protocols that they made will not work in the poor countries, and then there was a lot of abandonment of treatment, so they came out with simpler protocols for them. Eventually they realized that they must cut off radiotherapy as much as possible from the treatment. So lots of other things are happening over the years, and WHO in 2019 said cure all. So for all children they want treatment at least for 6 cancers, and out of those 6 cancers, Wilms tumor is the only solid tumor that they feel that everybody should be saved. So clinical presentation, we all know, I'm not going to go into it, is usually asymptomatic mass. There are few of them who have got symptoms related to metastasis. There's times when there's severe subcapsular hemorrhage, we call it as Ramsay's tetrad. Workup is also more or less been standardized by both the cooperative groups. The only difference that has come is that now the chest X-rays are kind of out, and both the PSYOP as well as the NWTS, which since 2002 is now known as COG, they want a CT scan. The new thing that has come up is that CT scan abdomen instead. People are talking about doing MRI abdomen so as to avoid giving any radiotherapy. CT thorax is more or less established, so no more chest X-rays ready for the initial diagnosis. FNAC true-cut biopsy through the retroprinted. I'll talk about a little in detail in another slide, so I'll avoid talking about it here. The liquid biopsies, that's the ones which are now making entry in the circulating DNAs and mRNA. That's not only for the diagnosis, but also for the follow-up and recurrences and treatment of recurrences. So first of all, we must understand that's a multimodal therapy. I see all the panelists, somebody is a radiotherapist, another surgeon or whatnot. Sure, we need all of them at times according to the risk stratification that I'm going to talk about. So this is what I was talking about, the transatlantic divide. So it all started in 70s. COG started doing immediate surgery, and PSYOP said, no, we must give preoperative chemotherapy to every patient possible. In India, like centers like AIMS, they would, if the small tumors come, they will follow COG. And if a large tumor comes, they will give neoadjuvant chemotherapy and then operate. I have a problem with that because when you have to compare your results with the Western world, they will not be mixing and matching like that. So either you follow COG or you follow SIOP. The problem was when I was following COG, that was till the year 2007, there were patients who came with very large tumors, 2 kg, 3 kg type of tumors. Patients knew that they have tumors for 2 years, come back to the capital Delhi to get treatment done. And usually they were metastatic, you couldn't do much about them. So 2007, 2008, I started going out, did fellowship in St. Jude's, then worked out SOP, and slowly then built up. My results were terrible till 2007, and 2023, my results are better than the Western world. So all that can be achieved with simple protocols, with simple chemotherapies. So this is the histological subclassification. So on one side is COG and on the other side is PSYOP. So we used to talk about favorable histology and unfavorable histology. And unfavorable histology was anaplasia, which they had found out sometime in 1975 or so. But then we talk about the PSYOP, they divided into 3 low risk, intermediate risk, and high risk groups. And you would see there's some difference there. The focal anaplasia has moved into the intermediate risk there. And surprisingly, the blastomal type is the one in the high risk group. Blastomal used to be favorable histology, but there's a difference. That is the blastomal cells which have not had neoadjuvant chemotherapy. These are the patients who had neoadjuvant chemotherapy and this cancer cell still survived. Out of the 3 types of cells that we have in Wilms tumor, blastoma is the most chemosensitive. So if you have a blastoma which is not chemosensitive, which is still surviving, that means there's something wrong about it. So tumor staging, I'll just rush through it. There's nothing much to say. Most of you would know it. The stage 1 is localized tumor, which can be removed. Stage 2 is which goes into the perinephric. Stage 3 is which is gone to the sinus, nodes, etc. And stage 4 is when you have METs. One is lungs and liver, which is a common. And then we talk about the patients who have non-pulmonary and non-hepatic metastasis, which again is a big risk factor. And then stage 5 tumors. So tumor stage is determined after nephrectomy. There are some articles you will see in the review which talk about tumor staging after doing CT scan. That's wrong. None of the cooperative groups have yet agreed upon those. So only once you have operated, whether you followed COG or PSYOP, you would do the surgery, send the tumor, then stage the disease. So risk stratification, there are a few things more that have been added. One is COG, staging and histopathology is there in both, and response of lung metastasis to neoadjuvant chemotherapy. In both the groups, if the lung metastasis disappear, then you probably do not need to give radiotherapy. Or if you are a little aggressive surgeon, if there are less than 3 pulmonary metastases, which you can excise along with the Wilms tumor, you don't need to give pulmonary bath to these patients later. So COG also includes, they started a study around 2000 and then which was defined as very low risk tumors, which I'll talk about the next slide. They stopped the study for a while and then again gone back to the same. Biomarkers or tumor biology has come in a big way in Wilms tumor. Only since 2005 COG is playing with it, and now PSYOP has kind of taken over. So I was talking about transatlantic divide. I'm very sure in next 10, 15 years, probably both the groups will have very, very similar protocols coming. And there are articles which already started talking about it. Recently, PSYOP has included volume of stage 2, 3 non-epithelial, non-stummal tumors, which after neoadjuvant chemotherapy are still more than 500 ml. They are given higher risk. So this is a risk stratification for favorable histology of COG. Very low risk tumor is when it is stage 1. Obviously, stage 1 cannot be known before surgery. Less than 2 years, and if the weight is less than 550 grams, these patients are not given any adjuvant therapy and they are just followed. If recurrence occurs, they give chemotherapy. Salvage chemotherapy gives good results. Low risk, standard risk, high risk. Then we talk about the rapid complete responders and slow incomplete responders. So if you give adjunct chemotherapy and the patient's pulmonary metastasis disappear within first 6 weeks or so, then these patients don't need a very intensive chemotherapy. They do not need pulmonary bath. But if they have slow incomplete response, then probably these patients need much more aggressive chemotherapy and also pulmonary radiation. This is pre-chemotherapy true cut biopsy. Now you would see there it is written UKCCG. UKCCG usually used to follow the same thing as PSYOP, but they were a different group. In fact, there was few differences that they do. They used to do a true cut biopsy through the peritoneal route for every patient. There are pros and cons for the same, but not enough cons. So now what we realized when the papers started coming from the South, East Asia, India, that the non-Wilms tumors are in the 15 to 20% of incidence, whereas the Western world sees it only 2 to 3%. For them to give up this true cut biopsy was pretty reasonable, but I still would do true cut biopsy in every patient, and not a single patient has got a needle seedling or any upstaging of tumor. But surprisingly, hardly 2 or 3 pediatric surgeons really do that kind of thing. So now the UKCC, which is now known as UKCCLG, which leukemia has been added there, and PSYOP have got similar indications to do true cut biopsy. So wherever they see age-related or biochemistry related, some variations which are not really normal, they would do a biopsy for the same, not for every patient, as they used to do till 2019 when they first started recruiting the patient under PSYOP protocol, umbrella protocol. We are all very interested in surgery. We are surgeons, most of us here. We'll talk more of surgery and less of the other things. Although in most of the government centers, including ours, All India Institute, the chemotherapy is still being given by the pediatric surgeons. It's simple chemotherapy, but of course, radiotherapy is a problem. Even in large institutions like Maulana Azad, you may not be able to get radiotherapy for such patients. So surgeons then need to know when are they operating and inform the radiotherapy suite at least 10 days in advance so they can book. And if the biopsy comes in favor that this patient has got stage 3 or needs to have radiotherapy, the radiotherapy should be started within the first 10 days of the surgery. Because there is no point, there's a lot of studies from COG which says there's no point giving radiotherapy after 14 days of surgery. If that is the case, then probably you keep radiotherapy as a salvage management in case a recurrence occurs. So as a surgeon, you have lots and lots to play with. You can do a pre-chemotherapy biopsies as I do. You can put a port or a pick. Now this radical nephrectomy, adrenal sparing, I'll just take 10 seconds on each. Radical nephrectomy, the whole concept had come from RCC basically in 1965 by Robson. Before that, the two fathers of pediatric surgery, that's Lads and Gross from USA, they had said you don't need to do radical surgery, you can do simple nephrectomy. And trust me, I have visited more of the world for this Wilms tumor workshops than anybody else in the world. And the masters also have seen them doing only simple nephrourectomy. So this word radical nephrourectomy should be removed from the textbooks in relation to Wilms tumor at least. The problem is, unlike adults, in children at times, the gyrotous fascia and the perirenal fat just is there. So it actually very difficult to make out which planes really you are going in. But since standard simple nephrourectomy is good enough for all. So total ablative nephrectomy is called when we do radical or we do a simple nephrourectomy. Adrenal sparing, because whenever they have done nephrectomies, they realize that the adrenal is involved only in about 4% patients, so they believe adrenal doesn't need to be removed. Partial nephrectomy, we'll talk about a little more about it. Laparoscopic bench surgery, I won't talk much. Only about 6 or 8 cases have been done in the entire world for Wilms tumor. Surgery for recurrence is to be done. Surgery for renal vein, IVC, atrium thrombus. And as I said, if you have only 3 or less pulmonary nodes, you can actually make a thoracoabdominal incision and remove those nodes along with removing the tumor. So this is the patient who was stage 4 disease. I can say stage 4 disease before surgery because he's got already a metastasis. If you see the thoracic, there's a peripheral small little nodule sitting on the left side. But the large tumor is there. So we went ahead, did simple nephrourectomy and also opening the diaphragm, we removed that little metastasis there. These are surgery for renal vein and atrial thrombus. We don't get to do such patients, and I don't get support from cardiothoracic to do really that kind of surgery, which is shown on the other where you remove the atrial thrombus. Such patients probably don't make it before they come to us. But these slides are, I was invited faculty, invited professor in South Africa. I spent 1 month each in many centers there. So this was from Cape Town, and I have their permission to show these slides where they have done IVC and whatnot. Incisions, there are lots and lots of incisions that are described, but majority of us would make a supraumbilical transverse incision, not crossing the midline, through the peritoneum will go. I know there are few surgeons who have done flank, but unlike the adult surgery, flank is not the one which we talk about, because, I'll tell in another slides, because lymph node biopsy is very, very important, and through flank we always compromise on the same. Cardiopulmonary bypass, of course, if you wish to do the atrial thrombus and all that stuff. Radical nephrectomy, I am not going to tell you what needs to be done, but you need to definitely take the ascitic fluid. There are very few surgeons who believe if ascitic fluid comes positive, whether these patients should have a whole abdomen radiotherapy. But I believe in this kind of therapy, because I worked with one Larry Hadley, who's written preface for my book in South Africa, and he used to be the last word on Wilms tumor management in the low-income group. Palpate renal vein and IVC. You must palpate them, although you may have imaging before, but do palpate, and if they are there, you remove them. If there is a hematuria as the presenting symptom and imaging shows ureteral extension, please perform pre-op cystoscopy and remove a cuff of bladder around ureteral orifice and repair the bladder. These are this for my book. So there I have explained what is radical nephrourectomy and what is standard simple nephrourectomy. I have always done simple nephrourectomy. This is another concept many people will not agree with, but I still have to, there are papers for that. The purest or the classical teaching is that we must attack the hilum first and then remove the tumor later. But all my career I have, because the tumors are so large, getting onto the hilum is not that easy. I have always first separated and attacked the hilum the last, and I have had no problems or no recurrences or whatever. So partial nephrectomy, bilateral syndromic, other selected patients like solitary kidney or those who already have renal insufficiency, no doubt we need to do partial nephrectomy. But the new concept that has come is that if the patient has got unilateral polar or peripheral small Wilms tumor, where at least significant part of the kidney could be spared after the tumor resection, go for it. It's really not a new concept. The Italians have been doing it since early 1990s, and in the systemic review, which I will talk about later, wherein I collected more than 300 patients from all over the world literature, very, very close scrutiny, every paper, the PDF was read, and I will share those in the next 2-3 slides. So we all know about the syndromic. I don't need to kind of go into the details. Wager, Dennis Drash, Beckwith, Wiedemann, these are the patients who would probably have a metachronous tumor. So be conservative when you operate these patients. So bilateral Wilms tumor results have been, even if you see 90s, the results used to be that 80% survival, so 5 years, 10 years. So Rickham in 1957 had said that nephrectomy should be done in the more involved side and do partial nephrectomy on the less involved side. But now the pendulum is shifted, and we all believe in doing bilateral NSS, whatever the case may be. So we avoid doing total nephrectomy and initial surgery, and majority of the patients in COG as well as CEOP, they get preoperative chemotherapy. So this is bilateral Wilms. If you would see very large tumor on the right side and a central tumor, hilar tumor on the left side. So what do? We give pre-op chemotherapy. We see whether the chemotherapy has result in shrinkage. At every stage, we would do a radionuclide study to know where we stand. We do a tumor volumetry, and then we will go ahead and do whatever. So if you would see large tumor, such a large tumor, I doubt very much if people would ever do partial nephrectomy, but I've done partial nephrectomy and saved just a little lower upper pole there, which probably may have only about 20% of the function left. But to start with also, this was the only function that this right kidney had. So on the left side, there was a central tumor, which could also be excised, large tumor on the right, small central tumor on the left. So this is what I was trying to tell you, that preoperative, it was the same function on both sides. So if I have been able to save the kidney still has function. Not the same patient though. So, so what are the benefits of doing nephron sparing surgery in non-syndromic, non-metastatic unilateral Wilms tumor? These are all actually taken from the adult urology, the experience with RCC really. Metachronous bilateralization, we knew trauma to the kidney, which may be the only kidney left, hyperperfusion nephropathy in the long run. And PN and adults had shown the diminished risk of cardiac related events. So as I was talking about that paper now, that was the nephron sparing surgery, which I have published in 2022. Which has got more than 306 patients, entire details. And I must mention a urologist's name here. This is the paper. That gentleman is Rajendra Narli from Belgavi. We are probably the only two people who are doing NSS in unilateral Wilms tumor, and he is the pioneer in India. He has published these two papers, and the second paper, which was published in 2020, is the only RCT in the world where he's compared patients who had radical nephroureterectomy with the nephron sparing surgery for unilateral Wilms tumor. And he's proved that over the years, very long follow-ups, that the use of antihypertensive and them having CKD is higher in patients having nephroureterectomy done for unilateral Wilms tumor vis-a-vis NSS. So this is how it all started. People initially said if you could save half the kidney, good enough. Now people say if you can save 20% of the kidney, that is also good enough. But with the umbrella protocol, which was announced in 2016, they have started recruiting patients in 2019. They say that in case the patient is non-syndromic and the unilateral Wilms tumor volume on the initial CECT is less than 300 ml and lymph nodes are not big on the radiology, then you can probably do NSS, which is okay. So we have started doing prospective multi-institutional study in 8 centers. I am the principal investigator. A lot of AIMS and PGI Chandigarh and Belgavi and so many other institutions, KGM. A lot of people are involved Let's have the reports coming in about 6 years from now, because we're going to talk about the 5-year results. What are the there are a lot of contraindications. So you have to pick and choose the patient. Not every patient can have NSS. Anaplasia, if it's there on the preoperative biopsy, you not do it. Pre-op tumor rupture, tumor infiltrating into hilum, extrarenal, tumor in the nodes, you're not going to do it. But earlier they used to say that, you should be able to save half or 2/3 of the kidney. Now, no more. They say even 20% kidney should be saved. They used to say don't do it in central tumors. Now, if you have experience, you will be able to remove the central tumors. Adult urologists, they've been removing central tumors for RCC for donkey years already. So involvements of calluses, hematuria, you can still manage it. I've already discussed this algorithm. I can share with people who are interested. Now, it's very important that umbrella says that the surgeon should write the surgical technique, surgical resection margin, pathological resection margin, and remaining renal parenchyma in the file if you have to later compare the results. And NSS-A and NSS-B is what NSS-A is partial nephrectomy and what NSS-B is basically enucleation. Although the umbrella protocol of SAB says don't do enucleation, go for NSS-A, but so many times when the patient has got hilar tumor, etc., you have no choice, and enucleation is very fine. I've removed tumors in 10 minutes actually by doing enucleation. So just another 3-4 minutes and I will be done. This is a patient which had 12-month-old female with a left abdominal mass. We gave chemotherapy. The tumor size decreased by 15%. This patient, the tumor size decreased only by about 4%. So very hard, very difficult to predict which patient will have reduction of tumor, which will not. This is another patient who had a large tumor. This patient had significant reduction, almost half the tumor. Then we went ahead and did NSS for this patient. Now, this patient, if you would see, if you could see the top, that side, you would see a botrite tumor, the upper pole tumor, which is almost to the hilum, and it is actually extruding in. Botrite tumor is what is extruding into the pelvis. So I removed a part of the pelvis along with that tumor, and the patient did well, and she is recurrence free for last 4 years. Case 4, this is 82% reduction. So some of the patients who had such large tumors to start with will have a very, very small. So as yet, I do not know which tumors shrink, or maybe once we do more of tumor markers and those kind of studies, we probably will know. So case 5, it's a central tumor sitting right at the hilum that we had removed. Ischemia, most of the things that is mentioned in the literature, people are doing zero ischemia. So nobody is putting a clamp on the artery or the vein and getting away with it. I have done almost 2 dozens without doing it. Positive surgical margin. This was one thing against NSS all the time. Schamberger, who was at one time chairman of NWTS, in 1990 had put up a paper that positive margins will increase the risk, you will go higher chemotherapy, etc., etc. But now lots and lots of paper are there where if Wilms tumor has got a positive margin, and chemotherapy and radiotherapy is almost there, and the results are very similar, so no problem. Duarte from Israel was the first person to do any MIS for Wilms tumor in 2004. He had done 2 cases, and after that, few people have started doing. But as of today, unlike RCC and the urologists here, not even 2% of Wilms tumor across the world globally have been done by MISS. One more thing is, if you have a very large tumor, as in our country, the NISS, by laparoscopy or robotic, they do it, they first attack the hilum as usual, as we do it in open, and then they mobilize. But if the tumor is that big that it's crossing the midline and hanging over the renal vessels, it's very difficult to do it, that you can clip those vessels before, and they don't want to kind of handle the rest of the tumor without the clipping the vessels. So large tumors, it's not possible. So what are the failures? Lack of lymph nodes. Lymph nodes that we talk about, you must take 7 lymph nodes at least when you're doing any. So if you do a flank, you don't take the nodes, this patient should be treated as stage 3 then, considering that the lymph nodes may be positive. Intraoperative tumor spillage has to be avoided at any goddamn rate. Since 2008, I haven't had a single tumor rupture in my, although I get large tumors. And unjustified incomplete resections are totally to be avoided. I have seen in this very city of Ludhiana, in a small clinic, I won't name the surgeon, in a 4 by 4 foot room, somebody was doing Wilms tumor resection under ketamine. No concept of chemo, no concept of radiotherapy. If that happens, of course, you're going to have recurrence, you have all kind of problems. So let these tumors be handled by those who know how to do it. This new concept in 2022, this paper has come, first time anybody has mentioned about sentinel lymph node biopsy. So basically what you see 8 is the aortocaval nodes. So these are the nodes which definitely should be looked for. So it's only berry picking, you're not doing RPLND, but these at least 7 nodes should be removed. So neoadjuvant chemotherapy, I believe large tumors as we get in India, we must definitely use chemotherapy. Very simple chemotherapy. If you have got localized disease, we will give actinomycin D, vincristine for 4 weeks. If you give metastatic disease, then you give it for 6 weeks, and here we add a third drug, doxorubicin. Giving this preoperative chemotherapy to them in my ward makes my rapport with my patients and relatives. Earlier, when we used to do a, surgery in the very first, patients would get the surgery done, and these are the patients who are from low socioeconomic groups, not very educated, and they'll disappear because for them the tumor is out. But you kept them in the ward, given them preoperative chemotherapy, you met them for almost 4 to 6 weeks, they have a rapport with you, then they will stick back and get surgery done, get chemo, get radiotherapy, and your results will really shoot up. I am not going to talk about this because I don't have time. The only thing which I will talk about radiotherapy, these are umbrella protocols, but COG also has protocols. By the way, COG gives lesser radiotherapy than PSYOP. So whole abdominal, whenever you're doing radiotherapy, you must make sure that the other kidney should not have radiation nephritis and patient should not go to end-stage renal disease because of radiotherapy. And COG gives, as I said, lower dose. What are the other things that are now coming up? mRNA therapeutic modulation, WNT signaling, and so these are tumor markers that are now coming in a big way. In COG, it has already been established. Immunotherapy, retinoic acid. And one thing more I didn't write, but I took a cue from, I've written in as a full chapter in my book is ablations. Sure, there are reports about doing ablation just the same way as RCC for Wilms tumor as well. So outcome prognosis is very good. If you start doing them and you be with them, abandonment shouldn't happen. If abandonment doesn't happen, good results even for a stage 4 disease with pulmonary metastasis alone, you have anywhere between 77 to 87%. And these are results published from India almost 5-7 years back. So India, as well as many other countries, have a lot of challenges. We don't have healthcare budgets. We don't have specialized pediatric surgical training for these tumors. We have inadequate reporting on histopathology. Data collection is poor. Delays happen in diagnosis. They come late to you with large tumors, metastatic tumor. Treatment abandonment used to be very, very common, still common in many centers. Malnourishment. I've done a thesis also in my department. Malnourishment, matlab, these children will not be able to tolerate your chemo, your radiotherapy, so you must focus. And when I was working in South Africa for a while, along with these two things, malnourishment and Wilms tumor, they will also have HIV, they will also have tuberculosis. So with 4 things, then even then, Larry Hadley would have fantastic results which could be compared to the Western world. And he will give INH to every patient who's under chemotherapy. Those are the things which pediatricians don't agree, but if you are the boss, you're giving chemo, you whatever, you can do all that. So priority areas are we should have registries, early department, adapted treatment. As early as 1990, PSYOP had come out with adapted treatment protocol that if you are not rich, you can't, your patients are poor and your patients are physically also not that good, so give them the adapted treatment and they also give good results. Nutritional program very important. family education, twinning programs. Okay, so these are the carry home messages. Use any one of the two. If you want to do upfront surgery, you should be doing upfront surgery for everybody. If you want to give upfront chemotherapy, which is my choice and choices of many, then do that. Avoid intraoperative tumor spills at any cost. When local overall survivals go beyond 90%, start focusing on long-term morbidities, learn and perform NSS whenever feasible, avoid doxorubicin and pulmonary radiotherapy feasible. In low-income countries, we should take care of malnutrition and comorbidities, and the tumor markers and targeted gen therapies are on the anvil. You will hear a lot of it in next 5 years. Thank you so much.
Thank you, Dr. Jagesh. It was a very wonderful presentation, and it tells how much hard work you have done over the years. And now questions practically left. Just two queries. Why the COG group, they are not using new adjuvant chemo, and because of the known indications.
I'll come to that.
And second question is,
can I answer the first question first? I'll get confused. COG has expanded its indications of neoadjuvant chemotherapy in a big way. Early, let's say when I was trained and all that, COG was not giving neoadjuvant chemotherapy to anybody other than bilateral Wilms tumor. They didn't have a particular protocols. There were people who were giving neoadjuvant chemotherapy for, 36 weeks, 40 weeks, whatnot. Now it has been decided for sure. Schamberger was the guy behind it, with whom I worked as a visiting professor. 12 weeks and no more, and you have to operate. They have expanded. Now 30% even in America, Wilms tumor are getting neoadjuvant chemotherapy. So whatever they think may cause tumor rupture. So no more daring surgeons in USA. I was also very daring. I remember when I was young, I will operate any goddamn, Wilms tumor and land up with a huge rupture. And the patient will come back with a large recurrence within 2 months. And then you don't know what to do. So you give higher chemotherapy, radiotherapy, patient is already malnourished, going to die. So now, although it is still said that they do upfront surgery, but as much as 1/3 or 1/4 of their patients now started getting neoadjuvant chemotherapy. As I said, these two protocols are going to be very similar in next 10 years. They're going to be working on similar things in near future.
Second question is, very, very impressive long-term survival disease-free, more than 95%, even in the stage 4 with lung mets. Is the survival difference between the different risk categories like low, intermediate, high risk? Because we used to see a lot of patients when we were doing DM at AIMS, but very less in the general practice in Ludhiana. So what is your experience?
Oh, yeah, of course. So when we talk about overall survival for the entire group, then even my own results before 2007 were, trust me, not even 40%. Now I can say my results are 95%. But obviously, if I'm trying to treat a patient with Wilms tumor with non-pulmonary, non-hepatic metastasis, then the results are not that good. Suppose the patient at the time of diagnosis already has got brain mets or bone mets. These are patients not going to survive. And we need to wonder whether we should waste our resources or just give palliative treatment to this patient. So we should decide whether we are going to work on this category of patients or we should just give them palliative treatment and don't do much. Because these patients are not going to make it, not in our scenario.
Thank you very much, Dr. Jagesh. It was a wonderful pleasure.
Thank you so much. Thank you so much.
For last 2 days, we discussed surgery, medical oncology, radiation oncology. Last but not least, the prevention is better cure. So I invite Dr. Mahajan to talk about shingles, that is vaccine for herpes zoster virus. Dr. Mahajan, please.
So I'm reminded of the T20 matches when Virat Kohli is at 99 and the advertisement suddenly comes on TV and you're waiting for the last ball to hit 100. And I'm standing between you and lunch, so I'm going to make it very, very concise. I'm not going to depend too much on my presentation, but just give you some carry-home points. I'm Dr. Monica Mahajan. I'm the Director of Medicine at Max Healthcare, Saket, New Delhi. So I'm going to be talking about something in terms of the fact that all of us practically have risk of getting shingles. Shingles is nothing but the chickenpox virus, which we are exposed to in childhood. And this virus goes and hides in the dorsal root ganglion. And as you grow older, the immunity of the human body keeps going down. Our innate immunity goes down. And people above the age of 50 years are especially prone to having the reactivation of the chickenpox virus, which is called as varicella zoster or herpes zoster. Why I'm talking about this particular entity today is that we've been eagerly waiting for the shingles vaccine or Shingrix for many years, but then COVID happened and the vaccine got delayed for launch in India. But our colleagues in US and Europe have been using this vaccine for more than almost 8 to 10 years with excellent results and excellent efficacy of almost to the tune of 94 to 95%. Now, there was an earlier vaccine which was available, but that vaccine was a live attenuated vaccine. And if you remember from your medical college days, live attenuated vaccines cannot be given to immune compromised patients or cancer patients. But unlike the earlier vaccine, the Shingrix is not a live attenuated, it's a recombinant vaccine. So this is a very, very appropriate vaccine for giving to patients with immune compromise. Having made that point, also let me tell you that the number of patients I see in my OPD with herpes post-COVID, because of the fact that we use so much of steroids during COVID, the number of patients of herpes in the last 1 or 2 years has become almost 10 times of what we used to see in the entire practice in my last 30 years. I've seen in the last 2 years is the kind of burden of herpes that I'm looking at. And practically in every family out here, you would know of your parents, your relatives who would have had herpes. And more than the herpes is the challenge of the post-herpetic neuralgia. So these patients not only have eye involvement in terms of herpetic ophthalmicus or other complications, but any pain which lasts more than 3 months in a herpes patient is called as post-herpetic neuralgia. And post-herpetic neuralgia, whether you give them pregabalin, gabapentin or any other medicine, they'll keep doctor shopping and go from one doctor to the other. But post-herpetic neuralgia is something that you live with and you agonize with. Imagine a person feeling electric shock-like sensations multiple times in a day. So if you've had any electrocution in your life, you'll understand having multiple shocks happening throughout the day for years together is post-herpetic neuralgia. And that is the reason that for such a disease which does not kill, but it improves, it actually worsens the quality of life of a patient. What we need to do is in terms of improving their quality of life by preventing shingles in the first place. So this talk today is not in terms of showing you a lot of slides, but in terms of telling you that in terms of this is a vaccine preventable disease. If you are offering the patient shingles vaccine, there is almost a 94 to 95% prevention of having herpes. And on top of that, the probability of getting post-herpetic neuralgia again reduces by the tune of almost 93 to 94%. So what is the people who are going to be getting this vaccine? So in India, the vaccine has been approved for everybody above the age of 50 years. So it's not just for your patients, it is for you and me also to be taking this vaccine. This vaccine is for anybody above the age of 50 years. You can give it to your patients, to your parents, and to yourself. And this vaccine also works very well in the immune compromised individuals because there is safety data and there is efficacy data to show that even in patients with cancers, with HIV or with any other kind of solid organ transplant, the vaccine has an efficacy to the tune of almost 90%. So I'm going to be just talking about the vaccine per se in terms of what it looks like. This is the Shingrix vaccine. It's a recombinant adjuvanted vaccine, which means that it is a part of the virus which has been taken as the antigen, which is called as glycoprotein E. And this glycoprotein E has been adjuvanted, which means that when you add something to the vaccine to make it more powerful for a longer lasting immunity, that vaccine is called as an adjuvanted vaccine. So it's a recombinant adjuvanted liposomal vaccine, and the packing comes as 2 vials. One is the vaccine itself and the other is the diluent. So you mix the diluent into the vaccine to get the vaccine ready. And once the vaccine is ready, it has to be used within the next 6 to 8 hours, or ideally on the spot. It's a single dose per vial, and 2 doses are required. If you give first dose today as day 0, then the second dose is between 2 to 6 months. And after that, lifelong, you don't need to repeat another dose of the vaccine. So 2 doses of the vaccine, and that is providing you almost 94% prevention or efficacy against getting a shingles attack and preventing post-herpetic neuralgia. So the dose of Shingrix is 0 and second dose is flexible from 2 to 6 months. As far as the safety of the vaccine is concerned, it's a very, very safe vaccine, hardly any side effects, and the Europeans and the Americans have been using it for a decade without any major adverse events in millions of doses used so far. The only side effect that you have to warn the patient is that you can have a little pain at the vaccine site or may get a little bit of fever, which a simple paracetamol tablet will work very fine in terms of preventing. So it's a very largely investigated vaccine. I'm not going to bore you with the details. The 2 major studies have been the Zoe 50 and the Zoe 70. So Zoe 50 was zoster efficacy in people above 50 years of age, and Zoe 70 was in people above 70 years of age. So this vaccine is targeted for anybody above the age of 50 years, not just patients, but any of us. It is recommended. If you've seen one patient of herpes in your life, you will understand what post-herpetic neuralgia does. It's described as a pain worse than having a labor pain. And people would not want to go through that agonizing experience. So I'm leaving out all the details, but I'm focusing on the fact that this has been given in patients with stem cell transplant. It has been given in solid tumor patients receiving chemotherapy. Renal transplant patients, we have a separate study which has been done in renal transplant patients with Shingrix vaccine, and in also HIV infected subjects. So it has an approval in almost more than 50 countries now, and with millions of doses already used, we as physicians are very, very excited with the vaccine. And in my own practice in the last 3 months that the vaccine has been available, I have practically offered it to a lot of my geriatric patients who were immune competent. They were not immune compromised, but even in immune competent patients, it's creating a wave because people are coming and demanding. Once they've seen anybody amongst their relative and friends having shingles, they understand the pain, the agony, and they are asking that please give us the shingles vaccine. And Shingrix is working very well. We haven't had any adverse events majorly reported in my hospital at Max in Delhi. And we've offered, and we are continuing to offer the vaccine to a lot of our patients. So thank you so much.
Thank you, Dr. Monica, for explaining it so nicely. And when everybody was waiting for lunch, I think you kept our concentration on, and thank you for that.
Thank you so much. Thank you.
Thank you.
Thank you, chairpersons. Now I will request the local organizing team to make the arrangements for the valedictory function. The last 2 sessions have been moved to Varanasi conference because of the paucity of time. Many had to leave. So.
अभी और भी है? सुबह लेट शुरू हो ही जाता है।
मुझे कंफर्म था, मैंने उनको सुबह देखा said me that he doesn't want to take a leave for
बाद में ले लो, एक साल के बाद नहीं, साल बाद क्या महीने में सामने बिठा लो, नहीं एक साल, ये आपका काम मिनिमम गारंटी कर देते हैं ना, कंसिस्टेंटली नहीं होगा तो काट भी नहीं, वो तो कम कर रहे हैं, जो घटा ना हमारे अस्पताल वाले भी आगे मेरे पास सीखे देख क्या चाहिए कोई बंदा बढ़िया आपको चाहिए क्या रिप्लेस करने के लिए मोहाली नहीं जाएगा कोई मोहाली वाले वही नहीं हमें लोअर लेवल पे पटपट बंद करना चाहिए लोअर लेवल मतलब जिसमें एमसीएच अभी एमसीएच या ट्रेनिंग यार तो बहादुर भाई यार थोड़ा सा एक तो आप उसके लिए कोई चाहिए नहीं देखो एक अलग मैं तुमको हाँ थोड़ा सा ना
सर आओ प्लीज सर तो स्टार्ट करिए सर 15 मिनट
फॉलो कर लो आप पढ़ लो चलो
सबने सर लोग चंडीगढ़ से Good afternoon, everybody. I will request everybody to just be seated. It will be a short ceremony. Sir, please have a seat, sir, please. May I request the President NZ USA, Dr. Vijay Bora, to kindly come on the dais. May I request Professor Baldev Singh Aulak, Dr. Amit Tuli, and Dr. P.P. Singh, please, sir. Now may I request the organizing chairman, Dr. Baldev Singh Aulak, to say a few words.
Yeah, my respected teachers, President Vijay Bora, Dr. Kamaljeet, and all of North Zone and beyond North Zone. It has been my wonderful experience to organize this midterm CME. I organized many conferences, but this time, from my core of heart, I got support from all my seniors to whomsoever I talked about this program. And I told my wife, this is the first conference where I am stress-free. I never had any stress. I handed over the responsibility of the workshop, which was very, very difficult. All the cases were very difficult, to esteemed faculty in whom I had the faith and who really carried my faith forward without even, thinking about their own hospital. Whenever we said, you have to spend 3 days, they said, okay, we'll spend 3 days. Now you have to come this time and take over all the cases they came over. Whomsoever I talked to my senior teacher, you have to please talk on this and have to come on this day. They said, okay, are you Baldev, are you requesting or are you ordering? I said, no, it is my request, but you have to come. So everyone obliged, and especially my North Zone Council, whose I has been the past president. I'm really proud of you all who had the faith to allot this CME to Ludhiana. And we carried, I think we carried with our whole heart, hard work and everything. Whatever you said, we followed that. And then the whole thing is in front of you. And I'm really thankful to all of you, my teachers, everyone. Thank you so much.
Thank you, Alok sir. May I request the President NZ USA, Dr. Vijay Bora, to say a few words.
I won't take much time. Thank you. I congratulate Dr. Olak sir and Dr. Amit Tuli, Dr. Nitin for hosting such a nice conference, nice midterm, and but I feel slightly hurted by seeing very less representation of the Ludhiana team in the conference. As a midterm, North Zone was given to the Ludhiana under the able leadership of Dr. Alok sir. But I don't know the reason for disagreement, but with the hope that these things won't be repeated. Thank you. Once again, I thank you very much to all of you. Thank you.
Thank you, Dr. Bora. May I request Dr. P.P. Singh to say a few words, please.
And thank you, Kamal. Now, it is my privilege to congratulate the organizing team of ICAI Hospital, who under the able guidance of Professor B.S. Olak has organized this conference very well. The scientific content of the conference was prepared very well by Dr. Kamaljeet and others, and everything has gone flawless. They operated 9 cases in the workshop, and almost 60% of the cases were challenging, and they were performed so well. Except for a little bit of snag in the transmission, which I discussed with Dr. Olak, and he said he gave 200 Mbps capacity, whereas the demand was 100. So probably there was some rain and all, and then there was a little bit of snag in the transmission. But thankfully everything went off very, very well. Of course, the hospitality was extraordinary, and the stay was very comfortable, and everything was good. And Dr. Nitin and Dr. Amit Tuli have really worked hard to support the whole organizing team. I congratulate you all and look forward. Thank you.
Indeed, this operative workshop was an excellent one. This time we had at Ludhiana. I do echo the sentiments which has been said by the President NZ USA that I'm little disturbed by this fact as that the representation of the Ludhiana Association in this meet has been on the lower side. In fact, I will go one step ahead. I did find the Punjab not to be participating too high. Since I come from the state, it is my responsibility to find out the cause and get back to all of you and why it all happened. And I personally will seek forgiveness for any kind of shortcomings which you had during the CME. It is the moral responsibility of the secretary to get to details of everything and get it in front of the council. And I will be duty bound, and I will be 100% giving to the exact figure what are actually happened. But whatever it is, I enjoyed my 1.5, almost 2 days stay in Ludhiana. This was a cheat day for me for dieting for last 3.5 months. These were the last 2 days I enjoyed eating like what I used to do previously. So I know everybody is not tired. I'm also tired. I'm also in a hurry to go back home. This is the last CME under the aegis of the North Zone, and we will be now moving on to the first combined meet if it is approved by the council between the Rajasthani Urology Society, which is known as the Royal RUS, and the North Zone. at Kumbhalgarh in the September, but our annual meet is at Varanasi, and I extend my invitation on behalf of the council to all the members who are present here, and we will be sending an official invitation to all the members very soon. The abstract submission is on and the last date is nearing, and since we have a huge number of presentations which have come, we won't be giving any kind of an extension this time, and we want to make it clear. And sitting in front of me are my teachers. I seek their blessings for the upcoming Varanasi. It's going to be a big conference. I seek your blessings. And I always want my teachers to be there, because whenever things goes wrong, it is the first time as your teachers, they bail you out. So, but I was told by Dr. Sabnis that he is going somewhere else, but I will again request it, sir, in case you can make it, I will be more than happy. Now the time has come for the announcement of the quiz. We had both the winners are from the PGI Chandigarh. And let me take out the result. It is the first prize. May I request the President NZUSI to kindly come forward to honor both the prize winners. The first prize goes to Dr. Shovik Day from PGI. Second prize is to Dr. Shiv Kumar. Now, everybody can stand here and speak, but I would like the esteemed faculties and the urologists in the forum to kindly tell us where we went wrong and what was good in this meet. So. Sir, quick comments. Mike, sir, quick mic, please.
So I'd like to congratulate the whole team under the leadership of Dr. Olak. The most appreciable thing is that there is a very good, I will say, educative, operative workshop. In spite, we know all the difficulties which happens in organizing a workshop. In spite of that, the things went on very well, and 9 cases in one day in one hospital is very creditable. The second thing, the scientific program was very well made, and I think so. I personally enjoyed. I also learnt a lot, and I'm happy to see our young generation. They are coming up very well, and they all have done hard work in making their presentations and have done well. The hospitality, as usual, Ludhiana is famous for that. We have enjoyed several number of times, and this time also we really enjoyed here. Only one thing specific I want to compliment Dr. Olak, inviting so many senior persons. They are all here, and they all have participated in the scientific program. After long time, I'm seeing they are giving lectures and all that, you know. Thank you very much. Thank you all, and thanks.
Sir, one more information, and this operative workshop is live, and up till now on the YouTube, and up till now more than 400 have seen our program.
I came only yesterday evening, and but yesterday evening was fantastic. That hospitality was great, and this place is also great, like 7-star facility. So there is no hospitality is great. I just saw today's academic program, but program was very good. Academic content was very good. Only one complaint that this hall was too cold. Otherwise, everything was good. Thank you for doing excellent work.
Well, thank you very much. I think this was a wonderful meeting. And I must say that I have attended a lot of midterm meetings in various zones. And this meeting has really raised the standard of the midterm meetings. Definitely the credit to you all. Organizing the live workshop is a very, very difficult job. Wherever it is organized, to whatever extent it is organized, to whatever topics to take. Especially in this workshop, the long surgeries, complicated surgeries were shown. And in spite of that, if you were stress-less, I think the credit is to you. And the confidence you have in your team was fantastic. So that is very, very important. Of course, the scientific program was very well made. And the conference is successful if the scientific content is good and the organizational aspect is good. In this conference, both were absolutely excellent. I enjoyed my stay here. Thank you very much.
Thank you, everybody.
Dr. Nitin.
And,
Sir, Dr. Nitin wants to make a comment, sir.
And on behalf of organizing committee, I want to answer some concern raised by our Honorable President. I want to make 2 lines. Kamil ki na pucho. Kamil means perfection. Kamil ki na pucho, to khizar bhi nahi kamil. Khizar means farishta. Kamil ki na pucho, to khizar bhi nahi kamil. Jeena उसे आता है, मरना उसे आता नहीं. Thank you for your comments.
Hello, Baldev.
Sir.
Baldev. No. S.K. Singh says that I should say a few words. I'm one of the hosts. It's my conference. And it has gone so well, and I'm returning to Chandigarh more educated. And I hope this is a big inspiration for younger colleagues, and they will do exceptionally well in future. No? And credit goes to you, Baldev, for organizing this wonderful conference, hospitality, and big scientific content. We enjoyed.
Just I want to tell all my seniors that all cases operated, all their post-operative reports are excellent and everyone is doing well, and many of them have started taking orally today. The credit of scientific program, of course, goes to our council, but especially it goes to SK Singh. We sat together many times to make it final that it should be impactful. Then we sent it to the council, Kamaljeet and Bora, please approve it, or you rectify our mistakes, and wherever we want to put more things, we'll put in. And that's how the final program was made. Thankful to SK, and thankful to all my alma mater, PGI, who stood with me to carry out this flawless workshop, which was very, very difficult. 8 cases, all extra major surgery, and we finished from 9:30 to 5:30 within 8 hours. 8 extra major surgery within 8 hours. All 3 in 3 operation theaters. They worked simultaneously. Let me tell you how we planned. We did not extubate the patient on operation theater. We took them into the surgical ICU. We extubated there so that time is not wasted. We put the new patient over there. So that's how we were able to carry out all the surgeries.
Thank you, Dr. Olak. Now, may I request the President NZUSI and the President-elect NZUSI to kindly step forward. This is on behalf of the NZUSI Council, we want to present a small token of appreciation to the hard-working members of the organizing committee. To start with, sir, idhar aa jaye, photo bhi aana. I will request both the esteemed presidents of my to give a small token to Dr. Baldev Singh Olak, sir. May I request Dr. Amit Tuli? I think so. Amit, you can sleep tonight very nicely. Ma'am, ध्यान रखना है सुता रहे राती दवाई खिला के सुलाना है इन्हों. A beautiful share was narrated by Dr. Nitin Agarwal. May I request Dr. Nitin Agarwal to kindly come on the stage. the man behind the scientific program. May I request my teacher, my guru, Professor S.K. Singh, sir, to kindly come on this. Sir, I would request you to kindly stay back also. Sir, please stay back. Sir, you have to collect the token on behalf of Dr. Girdhar Bora also, sir. Girdhar has left back for Chandigarh. Girdhar was the backbone of the operative workshop, coordinating with me and everything. So, sir, I will request, please pass it on to Girdhar and our regards to him. May I request everybody to rise for the national anthem? National anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Please join us for the lunch, whosoever is left.